Recording in progress. To another Australian neonatal webinar, and today is my great pleasure to introduce Helen Liley. Professor Liley, I don't think needs any introduction. She's been an Australian legend in neonatology initially, and focused a lot of what happens immediately after birth: resuscitation, cord clamping, and of course what we're going to talk about today, which is birth asphyxia or hipóxico-isquémic encephalopathy. Helen's done fantastic studies in that field, and today she's going to present some of her work and hopefully an overview of, is there anything we can do in this realm of babies which are either having birth asphyxia or maybe even at risk of birth asphyxia. So Helen, over to you.
Thanks, Kurt. I'll just share my screen, if that's all right, get these slides up. Hopefully that's showing up okay, Kurt? All
if
good?
You make it, that one, this is good.
Good, excellent. So thank you, Kurt, and hello, everybody. I'm presenting the results of the PN study, which was a randomized controlled trial for preventing adverse outcomes of neonatal hypoxic-ischemic encephalopathy with erythropoietin. And I've definitely got to start by acknowledging the phenomenal efforts of my co-investigators, Rod Hunt, Iona Novak, Rachel O'Connell, our statistician, Lucille Sebastian, who helped write the NHMRC grant and work up the original protocol, Nadia Badawi, Sue Jacobs, Yvonne Wu and Roberta Ballard, and Sunny Jewell in the United States, Shannon Clough, who was a parent advisor on our original grant application, and Lisa Rasky and John Symes from the NHMRC Clinical Trials Centre at the University of Sydney, who've provided phenomenal advice and support all the way through for this study. I'd also must extend special thanks to all the site PIs, research nurses, clinicians and others at all our sites, without whom there's no way we could have done this study, and also for the parents who agreed in what must have been very trying and distressing circumstances to consider the enrolment in the study and agreed for their infants to participate. So in terms of funding, the study was supported by grants from the NHMRC, a project grant, probably now would be under the MRFF, but back then it was the NHMRC Progress Grant, project grants, also the Mater Foundation and Mater Research Institute and the Cerebral Palsy Alliance. And because I've also presented this study to a US audience, they always like you to talk about the fact that you've talked about off-label use of a drug, in this case, epoetin alpha, which was done under the Australian Therapeutic Goods Administration clinical trials notification process. And I don't think I've got any other conflicts of interest to declare. So I think everybody in the audience will already be familiar with the fact that neonatal hypoxic-ischemic encephalopathy is a persisting challenge for us, and not one that's necessarily going away. The current statistics suggest that it occurs in moderate or severe form in about 1 to 3 per 1,000 term and near-term births in high-income countries. We've just done a recent 6-year audit of cases in our own hospital involving a birth population of 60,000 births, and came up with a rate of 1.03 per 1,000. The rates are probably much higher in resource-poor countries because of less access to antenatal and high-quality intrapartum care. And the WHO has estimated that it may contribute to as much as 500,000 deaths worldwide annually. Not only does it have this high mortality and acute morbidity, but obviously the sequelae of hypoxic-ischemic encephalopathy can involve lifelong personal, family and societal burdens. So why is it not going away? Well, It has diverse antecedents and causes. In roughly half of cases, in a whole variety of studies, there's an acute intrapartum sentinel event. These include things like uterine rupture, severe shoulder or body dystocia, umbilical cord prolapse, and major fetal hemorrhage. But many of these events emerge rapidly and allow little time to intervene, even with the most skilled midwifery or obstetric practitioners. In the other half of cases, we're still not really sure what causes them. And so given this situation, many of the cases of HIE remain unpredictable and possibly unavoidable. Although, as I say, in resource-poor countries, there may be a much higher proportion of avoidable cases. So, given the situation of a baby being born with hypoxic damage to the brain, it's been recognised for a long time now. In fact, this is an illustration drawn from an editorial written by Donna Ferrero, a world-famous neurologist at the University of California in San Francisco, in the New England Journal in 2004, so a long time ago now. But Donna set out the fact that the event that caused HIE may be acute and sudden, possibly devastating, but in fact, there is a progression of events after that include an early phase of energy failure, oxidative stress, and excitotoxicity, a subsequent inflammatory response of the brain, and then repair processes. But cell death proceeds throughout all those phases and extends not just into the first minutes after the event, but hours to days to weeks. And these multiple cellular events and pathways causing ongoing cell death allow potential opportunities for us to intervene and possibly mitigate the damage. This is a slightly more complicated diagram of some of those cellular events. So there's an initial hypoxic-ischemic event that leads to acute energy failure in the brain and drop in ATP levels in brain cells. That causes both intracellular acidosis, but also sodium-potassium ATPase failure in cell membranes, and those have downstream effects. Those include oxidative damage within the brain, involving buildup of reactive oxygen species, microvascular injury and mitochondrial injury, leading to cerebral edema, but also iron and excitatory neurotransmitter-induced injury. So the sodium-potassium ATPase failure leads to massive depolarization and buildup of extracellular glutamate, activation of receptors that lead to a rise in intracellular calcium that also contributes to the oxidative damage. There's further events, including disruption of protein synthesis and degradation of cellular DNA. Nitric oxide in the brain also plays a role, and together all these events do lead to acute cell death within hours of the initial injury. But there's also a secondary phase of energy failure within the brain that during reperfusion and reoxygenation that can also involve oxidative stress, excitotoxicity, and inflammation. And it's probably particularly the secondary energy failure phase. So the primary energy failure phase, we may be able to mitigate with skilled resuscitation. The secondary energy failure phase is in the area where perhaps there's been most activity in terms of trying to look for pharmacologic and other treatments that might mitigate these pathways. So what are some of those pathways? Well, on this slide, I've sort of set them out by the headings on the previous slide. Everything in green is an intervention or a method that is already, I think, in standard use. Early identification, good supportive care, reducing stress, avoiding the metabolic and physiological derangements. To mitigate oxidative damage, there's obviously a lot of focus on avoiding hyperoxia, anti-epileptics, judicious use of those to reduce excitotoxicity, and therapeutic hypothermia interrupts many of the cellular pathways of cell damage and is also now well enshrined in practice. Enhancing repair and regeneration, early intervention programs have increasingly established evidence. Everything in grey on this slide are things that are perhaps still under investigation and not yet part of our standard armamentarium. Some of them are receding as areas of interest because of trials that have suggested that they are not so useful, but others, such as stem cell therapies and cellular-based therapies, are still emerging and under active investigation. So this was the background to when the PEARN study was designed, and the topics on this slide are adapted from a review article in Pediatrics written by Jeff Perlman back in 2006, which really set the scene. And around that time, erythropoietin was attracting a particular amount of interest because for a couple of reasons. One is that there was accumulating promising-looking animal and human data, but also it was recognized as something that was already in routine use for other reasons, and where the safety profile was pretty well understood. So a couple of different articles identified it, of all the things on this page, as being one of the most promising treatments on the horizon to mitigate HIE. So therapeutic hypothermia, we're quite used to using, I think, in this context now. This is from Sue Jacobs' systematic review, Cochrane systematic review on cooling for newborns with hypoxic-isquemic encephalopathy, published in 2013. And what it illustrates is that both selective head cooling in the top panel of the forest plot and whole body cooling resulted in statistically significant improvements in outcomes. In this case, the outcome shown is the combined outcome of death or major disability at the last date of follow-up, and the effectiveness of therapeutic hypothermia was such that the number needed to treat to benefit was about 7, which I think we all know is a pretty respectable improvement amongst all the different therapies that we use. So erythropoietin, again, around the time we were designing this study, it was hitting the headlines for all the wrong reasons. As having been identified as the way that Lance Armstrong had managed such success in the Tour de France and other cycle races. But we all probably know it just as well as a glycoprotein that's produced in the kidney and the liver. It promotes differentiation of erythroid precursors throughout life, including in embryonic life in the yolk sac, subsequently predominantly in the fetal liver, and then in the bone marrow. It's got other roles in response to and repair of cell injury, including in the central nervous system. So it's a molecule that binds receptor monomers in cell membranes, causing them to dimerize and then activate a series of downstream effector molecules. These include AKT kinase, which limits inflammation, decreases apoptotic cell death, and increases angiogenesis. STAT5 promotes cell survival, and the ERK pathways are anti-apoptotic, anti-inflammatory, and critical in neurogenesis and cell fate commitment in the central nervous system. EPO has also been described as increasing antioxidant activity and reducing cytotoxic cell injury. So bound to work, right? So erythropoietin is the molecule produced in our own bodies, but there are a variety of synthetic erythropoietic stimulating agents that have been on the market for quite a while. So recombinant human erythropoietin, which has an international non-proprietary name of epoetin, is produced in various biosimilar forms, alpha, beta, gamma, delta, and epsilon, all produced by various manufacturers, and all with fairly similar effects. There are limited studies comparing those different biosimilars, but the one we used for this trial was epoetin alpha. There are also other analogues that are such as darbepoetin, which has the same protein structure as epoetin, but more carbohydrate, lower receptor affinity, and longer half-life. And it has also been studied in some neuroprotection studies, but one might predict that it might have different characteristics in terms of penetrating the blood-brain barrier. So these various molecules are used for the treatment of erythropoietin deficiency anemia that can complicate renal failure and some other types of anemia, including anemia of prematurity. There are copious systemic receptors for these molecules, mostly in the bone marrow, but also in a variety of other organs, including the heart, the lungs, and skeletal muscle. Clearance is mostly by receptor-mediated endocytosis, and it's dose-dependent and saturable. What's the potential importance of erythropoietin in HIE? Well, a large number of animal studies have demonstrated the depot and its receptors are expressed in the central nervous system throughout life, but especially in the developing brain. There's increased expression on a variety of cell types following hypoxia or ischemia. And in numerous animal studies have suggested neuroprotective or reparative effects in the CNS. These animal studies have involved a variety of models of hypoxic injury, including putting a mother animal in 8% oxygen, ligating uterine arteries, ligating carotid arteries, and various other things. But the results are fairly consistent. And there have also been some studies suggesting that the effects may be distinct from those of hypothermia, suggesting there could be some synergy. There have also been some primate and small human trials that suggested improved clinical and MRI outcomes of HIE, and I'll summarize those in a couple of the following slides. So perhaps one of the most convincing of these is studies done in neonatal baboons with hypoxic-isquémic encephalopathy that was induced by umbilical cord occlusion. And in those baby baboons with a condition that fairly closely mimics human infant HIE, you can see in the bar graph on the left of the slide that of control animals in this particular model, all the animals had a normal exam and none of them had an outcome of death or the baboon version of cerebral palsy. In those animals that had umbilical cord occlusion and received a saline placebo, 43% had either death or moderate severe CP. Interestingly, in these experiments, and the numbers are fairly small, umbilical cord occlusion and hypothermia also had 43% of the animals with death or moderate severe CP. But in animals treated with both hypothermia and erythropoietin, then all the animals survived and were either normal or had only mild cerebral palsy. The panel on the right shows white matter anisotropy at 72 hours after treatment. The red signal indicates increased signal compared to the umbilical cord saline umbilical cord occlusion saline control condition, and increased anisotropy is shown by more red signal, and more anisotropy is associated with healthier white matter. So as you can see that in the hypothermia group compared with the umbilical cord occlusion saline control, despite the fact that the clinical outcome measures looked a little bit similar, that the white matter anisotropy looks better. There is red signal showing up in the white matter in that hypothermia control, in that hypothermia condition. But adding EPO, a lot more red signal in all the images, suggesting that there is that the white matter is recovering better in those animals. There have been quite a number of other studies as well. The El Mahdi study published in 2010 was an RCT of 30 term infants with HIE who received treatment for 5 days with EPO but no cooling. And in that study, the authors found improved EEG background, reduced biomarkers of oxidative stress, and better neurodevelopment at 6 months. The Zoo study had 168 term infants treated with a lower dose of EPO, again, no cooling, and they found a 20% risk reduction in death or moderate severe disability at 18 months of age. There was a series of studies in preterm infants that have shown mixed results, but with not all trials and not all outcomes suggesting benefit, but a suggestion of reduced mental development or fewer infants with a mental development index less than 70 at follow-up, and no safety concerns. Our colleagues led by Yvonne Wu at the University of California in San Francisco did the NEAT-1 trial, which was a safety and dose escalation study of infants who were cooled for HIE, and found no deaths or SAEs in that study, no polycythemia, and suggested that an EPO dose of 1,000 units per kilo per dose was likely to be optimal. Yvonne's group followed up with a phase 2 proof of concept study using the same 1,000 unit per kilo dose up to 5 doses, 50 babies, all cooled, and that study suggested improved brain injury scores and motor outcomes. Just showing that in a little bit more detail, these were the results on the Alberta Infant Motor Scale at a year of age, showing that 5.2% of the EPO-treated babies, but 19.3% of placebo-treated babies had low scores on the AIMS with a probability of 0.03. So moderate to severe disability was reduced from 19% in the placebo group to 8% in the EPO group. In terms of brain injury scores in that NEATO study, this was using the Trivedi scale of severity of brain injury. The distribution of none, mild, moderate, or severe was shifted, and with a significant indication of benefit in terms of reduced brain injury, as you can see. EPO has also been tested in other types of brain injury, particularly traumatic brain injury in adults, and a meta-analysis of randomized trials that was published in 2016 that included 915 patients in 5 RCTs. And that review found that the EPO significantly reduced mortality and shortened hospitalization times in patients with traumatic brain injury. So we wrote the grant for the PN study back in, it was 2013. It was funded in 2014, and in June 2015, we opened for recruitment. What could possibly go wrong? Well, the first thing that went wrong is that within weeks of us opening the trial, we received information that a similar trial being conducted in Paris, in France, the NeoRepo study, had been ceased due to adverse effects in the EPO-treated group. We didn't have much more information about that. It appeared that there were more deaths in the EPO-treated group, and quite a lot of the information about this trial was under embargo and was not published. But what we did manage to accomplish was that we convened our Data Safety Monitoring Committee, and they had direct contact with the IDSMC to IDSMC contact and sharing of data between the two data safety monitoring committees for our trial and for NeoRepo. And they, after that contact, they assured us that it was safe to continue with the PN study. It appears that with NeoRepo, what had happened was that the trial wasn't stratified for severity of encephalopathy at the time of recruitment, and so and what had ended up happening was that there was an excess of babies with severe encephalopathy included in the EPO-treated group at baseline. And the IDSMC was fairly convinced that this result entirely explained the difference in mortality. So our IDSMC recommended that we could restart the trial with revised safety outcome reporting and stopping rules, and we were given HREC approval to do that, and the first site was reactivated in May 2016. In the meantime, a US study very similar to PN and designed in parallel was awarded funding and also commenced recruitment a few months later. So this is the study design for the PN study. Babies were eligible if they were greater than or equal to 35 weeks gestation and had moderate or severe HIE. We definitely did stratify by site and by severity of encephalopathy based on modified SANAT criteria. The babies were treated with 1,000 units per kilo of EPO on days 1, 2, 3, 5, and 7, or a placebo control in a similar dose and the placebo was prepared in identical vials to the EPO so that the trial to improve the blinding. The endpoint at 2 years of age was a composite of death or moderate or severe cognitive deficit, and the sample size was calculated at 300 babies to detect a 19% ARD and death or moderate severe disability. Attention to treat principle for analyses and a safety endpoint of analysis by treatment received. The inclusion criteria I've mentioned, the greater than or equal to 35 weeks gestation, babies less than 23 hours of age at randomization with the intention of allowing first dose of treatment by 24 hours. The babies needed to meet the criteria shown on the slide for perinatal depression and then to have moderate or severe encephalopathy as determined by a modified SANAT score at 1 to 6 hours of age. Hypothermia begun by 6 hours of age and anticipated ability to collect the study endpoints at 2 years, as well as informed parental consent. We excluded babies who had severe intrauterine growth restriction, severe congenital anomalies, genetic syndromes or metabolic disorders, those who had severe microcephaly, and those for whom withdrawal of life support was being planned. By the modified SANAT criteria we used are shown on this slide. I know there are 2 or 3 different versions around floating out there in the world of modified SINAC criteria, but in our case, we focused on the level of consciousness, spontaneous activity, tone, suck, morrow, respiratory abnormality, and seizures. And a baby was eligible if they had any 3 criteria in either the moderate or severe column between 1 and 6 hours of age, or seizure, or any 2 criteria plus seizures any time prior to randomization. So we randomized in the end 313 babies. We slightly over-recruited because of issues with follow-up during the COVID pandemic. And that meant that we thought we would lose more than originally anticipated to follow-up. 156 allocated to EPO, 157 to placebo, and 1 baby allocated to the EPO arm had the consent withdrawn before treatment. We had safety outcomes available for all but that 1 baby who was withdrawn, but we had 7 lost to developmental follow-up in each arm of the study, meaning that at the end of the trial, we had survival outcome data available for 146 in the EPO-treated group, 149 in the control group, with as you can see, the deaths in hospital and after discharge being similar in both groups. For those of you who might have heard me present this study previously at the ABCC meeting or at the PAS conference, the numbers on this slide are slightly different because we've had a trickle of data coming in late from sites, so that our primary outcome determination has now been able to be determined for 89% of the 155 treated in the EPO group and 91% of the 157 treated in the control group. And thank you to everybody who has helped us to accumulate those results. This follow-up to primary outcome now looks better than it did in previous presentations of the study. So we had moderate encephalopathy and severe encephalopathy. The distribution was similar in both EPO and placebo groups. I haven't broken down all our 24 sites, but you can see the group by state or territory or country, that the distribution was pretty similar. In terms of baseline variables, these were mostly term infants, mean gestation over 39 weeks in both groups. Birth weights similar and mostly normally grown infants. Slight preponderance of males, which has been common in HIE studies, and about 40% of the babies inborn in both arms of the study. You can see there the distribution of vaginal, non-instrumental, instrumental, and cesarean births, and it was similar in the 2 arms of the study. A similar proportion, about between 20 and 30% of the babies who were induced. About 91% or about 90% were vertex presentations, 6 to 7% maternal fever. And of the proportion who had any of our predefined intrapartum sentinel events, it was 46% in the EPO arm and 47% in the control arm, similar to other studies. Cord arterial pHs, as you can see, were mostly quite low for those babies for whom we had cord gases, which wasn't all of them. The hours from birth until treatment was similar in both arms of the study. Nearly all babies received a calculated dose within 90% of that intended by the protocol, and nearly all of them received treatment on days 1, 2, and 3. We had made provision that, of course, babies for whom redirection of care was occurring, that they could cease study treatment, and also that if babies had recovered to the extent that they no longer needed IV access or being planned for discharge or transfer, that they could omit the last 2 doses, either of the last 2 doses, and that occurred. That explained some of those lower treatment rates on those later days. So what happened in terms of outcomes? Well, these are results for the primary outcome. The rate of death or moderate severe disability in the EPO-treated arm was 34%, and in the placebo arm, 29%. This result was not statistically significant. In terms of secondary outcomes, there was also no difference in death, in cerebral palsy, in motor deficit, in cognitive deficit, or in epilepsy at the two-year follow-up. We had a number of tertiary outcomes, and there were also no differences in any of these, including receiving nutritional or respiratory support at the time of follow-up, cortical visual impairment, hearing impairment, Bailey 3 cognitive language or motor scores at 2 years, level of motor or cognitive deficit, or global Durbowitz optimality scores determined in the second week of life. Safety outcomes, 13% of EPO-treated babies died within 30 days of study treatment and 11% of placebo-treated babies. And we had one baby in the EPO group who had new thrombosis of a major vessel within 7 days of study treatment and none in the placebo arm. There were no instances of our other predetermined serious adverse events of interest, which included CPR within 2 hours of a dose, pure red antibody-mediated pure red cell aplasia, polycythemia requiring treatment, or adverse events believed to be treatment-related requiring withholding of a dose. Interestingly, there were also no differences in any of these other variables: peak hemoglobin, lowest platelets, peak creatinine, coag studies, need for anticonvulsants, and single use, multiple use, or on anticonvulsant at discharge, any inotrope, or any respiratory morbidity. So we conclude from these results that in infants with moderate or severe HIE, high-dose EPO administered over the first week didn't reduce death or disability. There was no definite signal for harm, but the event rates are sufficiently low that for what were mostly rare events, that clinical benefit or harm cannot be conclusively excluded. Interestingly, we had lower rates of death or major disability than among cooled infants in the original trials of therapeutic hypothermia. And it's interesting to speculate, but I think there's a number of potential reasons for that. And I think the other thing I would suggest is that, arduous as everybody probably found this trial to conduct and complete, I think that there's still an important role for large multi-centered trials at low risk of bias for assessing important neonatal therapies. It's perhaps important to think back to when we began this study, and one of the most common questions that we received at the time was, can we offer this treatment off-label to parents who decline randomization? Because there was quite a bit of enthusiasm for the idea that it was probably going to work. So yet to come, Mary Gazawi, PhD student and neonatologist in Townsville, has been working with Rod Hunt and Malcolm Batten and others, and Iona Novak, undertaking analysis of the MRIs from the PN study and the AEGs, and also the general movements assessments that we collected on many of the babies in the study. We had originally planned a cost-benefit analysis, but not quite sure whether we're going to go to the trouble of completing that, because it's a bit hard to expect that we'll find a cost-benefit when we didn't find a benefit. We also collected blood samples from many sites during the study with the original intention of doing some extended erythropoietin pharmacokinetics. Since then, Adam Frymoyer and others in San Francisco have published some more pharmacokinetic results from the HEAL study, the study that was conducted in parallel in the United States, that make it seem that that's probably not the best use of those samples. So we're just at the moment assessing the feasibility of looking at protein markers of severity of HIE and for prediction of outcomes using those samples. And we also collected slides or reports of placental pathology on just under half the babies in the PN study. Of course, by the time babies were deemed to be eligible, a fair number of placentas were in the bin, but nevertheless, for the ones that we were able to collect those samples or reports from, we're collating those and intend to report the results. So I think the study also raises a number of interesting questions about why EPO was ineffective when all the evidence before we commenced the study suggested that it was likely to work. Was it the timing and nature of the injury? Is this different in human infants than in the animal studies, such that perhaps some of the injury is occurring sufficiently long before birth that EPO is less likely to be effective? Did we have the wrong timing, dose, or duration of treatment? I think that's a bit less likely, but still a possibility. Another interesting possibility is that maybe in these babies there's sufficient endogenous EPO production to maximize any benefit that might be derived, and that supplementing with pharmacologic doses doesn't actually add to that benefit. And one of the interesting things to note in there is the fact that we saw no difference, despite the fact that this is quite high dose EPO treatment, we didn't see any difference in hemoglobins in the two study arms, suggesting that there's already quite a high level of circulating endogenous EPO. Was optimal benefit achieved with therapeutic hypothermia alone? I think that's another possibility, that there's not much you can add to really well-conducted therapeutic hypothermia. And possibly the benefits of EPO that are seen in animals are not achievable in the more complex human brain. So that was all from me. I'm very happy to take any questions.
Wow, Helen, that was indeed, like John is typing, that was a great overview of, the use of EPO in HIE. This story, and we had this with several presenters who presented a clinical trial, this is a 15-year story. It started many years ago with the design, and when you finally started, you run into complex problems. But not only that, you try to solve a really complex multifactorial pathophysiology. You told us about, the search for what interventions, what to choose, and then importantly, and people learned from that as well, second, what dose, what duration, what height, etc. need to be explored, pharmacokinetics, if you try to start with medications. And then, of course, the pathway after start of the clinical trial with all its hurdles, and finally you get the results. And even though the results might not be, proven to be the benefit we were hoping for, the importance of doing a clinical trial of this size of a particular medication, I totally agree, is very, very important. So we got time for some questions. We got 15 minutes. Please type in or open your thing. John, you want to just unmute yourself and ask the questions?
Hi, Helen. Thanks for your talk. That was great, really good. And an amazing trial that you carried out as well. I have to say, the work involved in something like that is unbelievable. I just got a couple of questions. One was the interaction with the other non-apoptotic cell death pathways that seem to have been sort of realised more recently, haven't they, in the neuroblastoma studies and things?
I think that's a possibility, John. I mean, I think I can only speculate as to why, I don't have a definite reason why it didn't work. I don't think anybody does. And
No.
as you probably know, there's been a large amount of work looking at EPO in various models and various circumstances of brain injury, for the so-called encephalopathy of prematurity, as well as in HIE. And I think given the millions of dollars of grant funding and the enormous amount of effort that we and everybody else has put into this, the results are a bit disappointing.
Yeah. What was really interesting also was the reduced disability in the trial from the original trial. Yes. So it is showing maybe we are getting things right in terms of supportive care for these babies.
I think there's probably several reasons for that, John. I think that they probably do include the fact that we've got better at supportive care. I suspect that we're starting therapeutic hypothermia a little bit earlier. It's hard to distinguish that in looking at the previous clinical trials of therapeutic hypothermia, but I think now that we're not needing to seek informed consent for, we just inform parents, but not go through a consent process and things, we're probably getting onto it a bit quicker. And of course, with the availability now of servo-controlled devices and things, I think we may be providing better therapeutic hypothermia than in the past. But it's still encouraging to see. I mean, I think the results of this trial and the HEAL study both suggest these somewhat improved outcomes and perhaps should lead us to change our, obviously you've still got to warn parents of potentially bad outcomes, especially in the babies who have severe encephalopathy at baseline. But I think there's a good news story there too that is really worthwhile to know about.
Yeah.
Helen, I might have missed it, but was the outcomes stratified for severity of HIE as well? Did that make a difference?
Yes, we have stratified and Rachel, I didn't show that slide, Kurt, but yes, certainly severe HIE at baseline remains a predictor of much worse outcomes than moderate HIE. Having said that, then I think we've all seen some babies who appear to reclassify themselves over the first day or two, and so I think that this is still it's still worth having a go for the babies that have severe HIE at baseline. And then perhaps reassessing after a few days. It is an interesting possibility that there could be a secondary analysis that we can do because we've got a variety of measures of severity of HIE on each day of treatment in this trial, including clinical observations, so modified cyanate scores by each day of treatment, but also the AEG data, which which can tell us, we've already analysed those data, we just haven't completed the analysis overall of those results pending the final analysis of PN itself, but we will also have seizure burden and baseline AEG by each day of treatment, and so we may be able to sort of say something a bit more useful about, but if you haven't improved by, it's not going to get better, or if you've improved by day 2 or day 3, would you recategorize that baby as maybe moderate, look with prognosis more like that of moderate HIE? I think that's something that we can potentially look at.
Yeah, no, that's great because there's indeed numerous new studies out which help us prognosticate just better. Cheryl asked if the results of your study have affected other studies. Are people calling you up and saying, look, oh man, it didn't work, what shall I do now?
So probably, I don't think EPO ever became sort of enshrined. I think if I'm understanding the question correctly, I don't think EPO ever became sort of enshrined as an off-label treatment in Australia and New Zealand, at least. But certainly colleagues in places like India have told me that it has been used widely off-label in those countries. There is currently a trial underway examining its use as monotherapy in babies in those locations where cooling is either not available or has been construed to have disappointing results.
Yeah.
And so I probably would hedge and say, let's wait and see what the results of the trial are. But at the same time, we've just had published in the recent days a systematic review that we conducted for ILCOR of the use of therapeutic hypothermia in low and middle income countries. That review led by Henry Lee at the University of San Diego. And our interpretation of the results is that, notwithstanding the results of the HELIX trial, is that there is benefit of therapeutic hypothermia even in some of these countries, and that it shouldn't be discounted as a therapy too lightly.
Yeah, there's still a lot to explore in different settings with different criteria. And so one of the criteria we've been talking about, and by the way, Jan Klimek sends his regards and his compliments for you doing this particular study. Australia is the only country who puts 35 weekers into the therapeutic hypothermia group. And there is a discussion going on now nationally about, should we go what Worldwide is doing? And of course, there was a new trial showing that there wasn't much benefits between 34 and 34.
There was the recent large RCT from the United States that suggested that there was a lack of benefit in baby. That study actually examined babies 33, 34 and 35 weeks gestation, didn't it? And said that overall there was no benefit in those lower gestation babies. As many of you will probably recall, that we used the lower threshold of 35 weeks and 0 days because that had been the cutoff for the ICE trial that Sue Jacobs had led. And Sue has commented to me several times that there were only quite small numbers of 35 weekers enrolled in ICE, and the same would be true for PN. But I do have some slight concerns that there's got to be, I'm not quite sure where the exact, that we've really defined where the exact threshold gestation is. And I wonder whether there is a case to be made for an individual patient data meta-analysis involving all the studies that have had different gestation thresholds to try and discern this. I'm just a little bit anxious that we write off the possibility of benefit for, a 35 and a half week gestation baby who presents with a classic presentation of HIE.
Yeah.
I do think that there's an issue that the lower the gestation, the more difficult it is to be sure that of the clinical signs, because obviously at lower gestations, things like pauses in apneic pauses in breathing and weak sucking reflexes and things like that may be more a sign of immaturity than of encephalopathy. And so I have some hesitations about whether our methods of recognizing those babies are optimal.
Yeah, no, I agree. And talk about the preterm babies, and let's go even lower. What about HIE in babies less than 32 weeks? I know EPO has been used successfully, but that was, from my memory, just to almost everybody. What about you select those babies? Is there something to say for that, or should we trial it?
An interesting question. I guess the neuroprotection studies of EPO in very preterm or more preterm infants, some of those studies have started treatment quite soon after birth. Again, it may be worth looking in more detail at the group of babies who specifically were asphyxiated. Most of those studies in preterm infants haven't required asphyxia as a condition of entry to the trial, so they include babies who, had good APGAR scores good cord pHs weren't asphyxiated at birth, but it may be that a subgroup analysis that looks at those who were asphyxiated might offer some information. There's not so many of those babies, so it might again take an individual patient data meta-analysis of all the studies that have been done, the ones in Europe and the United States, and other locations.
Now back to the big group again, so 35 weeks and above, so the term is kind of babies with HAE. John already mentioned it, the outcomes were better, so we must be doing something better in the care, even after the event. Not only therapeutic hypothermia, but the way we give therapeutic hypothermia and the alternative sort of ways we support these babies. We all love the Queensland HAE guideline, which describes that in a lot of detail. Is there anything else you want to sort of add to that? Which one would you highlight? What is new and upcoming in how to care for these babies after an HAE event?
I certainly think that we've got a lot to learn about developmental care in general, haven't we? And early intervention. I suppose my suggestion would be is that we shouldn't underestimate the importance of skilled early developmental intervention. And I think the evidence is increasing that at least for some infants it can work.
Suzanne, you have a question? Just your hand is raised. Maybe not.
That I think that
all right.
A reasonably high proportion of the babies in care did receive early intervention among the survivors. That they even the ones that were lost to follow-uppers. I think that many, if not most of them, did receive developmentally supportive care after discharge.
Thanks, Helen. This is Susan from Western Australia. I would like to ask, is any different from the hemodynamic point of view, whether the EPO group stabilizes the patient better?
Question, Susan, especially since I mentioned that there are EPO receptors in the heart and various other places. We didn't collect very detailed information, and in particular, the many, we had 24 sites for the studies distributed over 3 countries. We didn't really have the resources to do detailed measurements that you might consider in the trial if we were starting it now, things like functional echo or near-infrared spectroscopy to look at brain perfusion and oxygenation and things. So I can't tell you a definite result for that, but what I can tell you is that we collected information about use of inotropes, and it was similar in the 2 study arms.
Yeah, thank you, Helen.
All right, and one more comment. I think, what you mentioned, half of the placentas were thrown away. Now, it's really, really important to realize, although we might not need it for clinical care in these babies, we would need it to investigate. There's a huge amount of new data coming out how the placenta and HAE can be very closely connected together. So please, if you have a case, even if it's suspect, do not throw the placenta away, but have it investigated. Let me see, there's maybe one more question. Amber.
So Amber asks a really good question.
Yes, should you stop early or not?
Therapeutic hypothermia. I don't think we've got good evidence. My suggestion is to use great caution because therapeutic hypothermia itself appears to have an anti-epileptic effect. And so I think some of the babies that you're calling, if you rewarm them early, you may think you're on the right track, and then they develop seizures and you wish you hadn't. And so I think we should use enormous caution in rewarming babies who we've decided to call. We hardly ever do that in our own hospital. I think probably the only instances of where we've ceased calling early have been because there's been a definite decision for redirection of care because it's evident that the brain injury is so severe or the baby's dying for other reasons, or the other reason why we've occasionally ceased calling early is because of things like severe uncontrollable pulmonary hypertension or uncontrollable coagulopathy or bleeding. But otherwise, we pretty much never do it because we think the baby's getting better. I'm afraid we make them do out the 3 days.
Look, and there's other consequences. We invited John Fenneroff to come talk about medical, legal consequences, which HAE will be 80% of almost everything a neonatologist will encounter. He will speak somewhere in November or December. Helen, it's 2 o'clock. Thank you so much for presenting this. This was an awesome sort of effort, work, study and a journey you presented to us, and thank you so much. Thank you all again for presenting again, for attending again. We'll be back next week. Professor Alex Kemper is going to talk about jaundice, a topic we deal with every day, which is good to get an update on as well.
And could I just again, Kurt, I can see quite a lot of the names on the screen of people who made an enormous difference to the conduct of this study, of the design, the conduct, the outcomes. And so thank you very much to everybody who had anything to do with it. Certainly couldn't have done it without you.
All right, thanks, Helen. Hope to hear from you and your other studies and work again in this webinars next year.
And hoping to submit the paper for publication within 2 weeks. So if any of you get to review it, thanks very much.
Thanks, Helen. Thanks, everybody.
Yeah, thanks.